Coming to the very important topic of retinal vascular occlusions, we'll start the topic by covering the retinal venous occlusions. Now, retinal venous occlusions can be classified into a central retinal venous occlusion, a branch retinal venous occlusion, and a hemicentral retinal venous occlusion. This is basically because of the pattern or the anatomy or the localization of the occluded vessel. If it is more proximal towards the optic nerve, and the occlusion is at the optic nerve head, it is a central venous occlusion. If it is at a branch, which is a first or the second division branch, it is called as a branch venous occlusion. A branch distal to that is called as a minor BRVO or minor branch venous occlusion. A hemicentral retinal venous occlusion is essentially an anatomical abnormality of a retinal vein, because of which the pattern of occlusion is slightly different. All in all, these two occlusions are classified into ischemic and non-ischemic. That is what we are going to look at, and which is most important in terms of the prognosis. The CRVO is the central retinal vein occlusion. It presents as a sudden painless loss of vision. It is classified depending on the clinical picture into the ischemic and the non-ischemic variants. Ischemic type, as we have seen in the previous flowchart, in the previous discussion on vascular problems of the retina, that it has devastating neovascular complications as a result of the common pathway of VEGF, which has been discussed in the other talk. Predisposing factors for venous occlusions are systemic factors, which, if we can recollect the Furkoff's triad in pathology, these are the increasing age leading to atherosclerosis, systemic disease such as hypertension and diabetes, and hypocoagulable states. So essentially factors outside, within and inside the walls of the blood vessel. Ocular factors which contribute to the central retinal venous occlusion are raised intraocular pressure, congenital anatomical variation of the central retinal vein, and inflammations like periphlebitis. Now the occlusions, as we have seen, is vasculitic and non-vasculitic. Periphlebitis is essentially a form of vasculitis, and inflammatory occlusions, the central retinal vein, can also occur. The differentiation in between these two variants is absolutely important. The differentiation can be done by means of looking at the visual acuity, the relative afferent pupillary defect, extent of the hemorrhages in the retina, presence of cottonwool spots, degree of disc and macular edema. All are worse in the ischemic type. However, 34% of the non-ischemic variants later get converted to the ischemic variant with due course of time. So adequate follow-up and regular follow-up should be maintained, because this conversion, which if goes unnoticed, can lead to devastating complications, so much so loss of vision and loss of the eye. So in the long run, because these convert into the ischemic variety, we need to follow up the patient at least every monthly for the first 6 months. The investigations that need to be done in cases of vascular occlusions are a subpart of the investigations we did for the vascular diseases. The ocular investigation which is most important is the fundus fluorescein angiography, which shows the classical CNP areas or the capillary non-perfusion areas, which we discussed as the basic finding of an angiogram in case of a ischemic pathology. We'll be seeing this in the next slide. The systemic investigation depends on the patient profile. As we have discussed, two classical presentations in terms of age group. They can be either a vasculitic age group or vasculopathic age group. The difference being the vasculopathic is the age with hypertension, diabetes, etc., which come as a natural add-on in terms of age, whereas vasculitic age group is the one which are the relatively younger patients. In those with a vasculopathic age group, by and large, we do not need to do too many investigations except the routine hemograms and measuring the blood pressure. Whereas in the vasculitic age group, we need to specifically look at hypercoagulable states and the causes of vasculitis. Apart from that, a look needs to be given to different agents like protein C, protein S, antithrombin 3, etc., which promote coagulation and can cause occlusion in these cases. Treatment. Pharmacotherapy with non-steroidal anti-inflammatory drugs, as was the denominator to treat macular edema in all these cases, is same as for all other vascular diseases. It is important to be remembered here that macular edema can occur due to a vascular occlusion, maybe a microvascular occlusion or a macrovascular occlusion. It is basically a reflex that takes place at the macula because of the capillary problems. The monthly observation in cases of ischemic CRVO for signs of neovascularization is very important. The sites of neovascularization, as we have discussed in the flowchart, were the iris, the anterior chamber angle, the peripheral retina, and the disc. At every stage in follow-up, it is important to look at all these four sites not to miss the first sign of neovascularization, because that indicates the time of initiation of treatment. Treatment with panretinal photocoagulation in cases of CRVO or central retinal vein occlusion is initiated at the first sign of neovascularization. It can, however, be supplemented with the help of anti-VEGF agents, which we have discussed in the common denominator for treatment, which can supplement or give us time till we complete the photocoagulation in case the neovascularization process has set in and is already advanced. Most important of all, the predisposing factors that cause the occlusion need to be treated, and they are to be accounted for by an internist or a physician who co-manages the patient as the need may be. Coming to branch retinal venous occlusion, which is the second part, it is also classified into ischemic and non-ischemic. The presentation is slightly more subtle, but because it involves only a part of the retina and not the whole retina as involved in a central retinal vein occlusion. Now, the patient does come more with macular problems and macular edema, the symptom of which is classically metamorphopsia or abnormal shape or distortion of the image of the object. Apart from that, in case the patient presents to us after a neovascular catastrophe has occurred, the patient will come with sudden painless decrease in vision as a result of vitreous hemorrhage. Signs on the retinal examination will be a segmental dilatation and tortuosity of the blood vessel instead of the 360 degrees involvement in case of a CRVO. The hemorrhages in the affected sector and the cotton wool spots that will be commensurate with the degree of ischemia. Cotton wool spots essentially are the indicator of nerve fiber layer infarct, and the more the infarctions, more the ischemic component. Basically, it is as considered as a clinical corollary to the extent of the perfusion. Hard exudate formation or leakage of lipids and proteins from the incompetent capillaries occur at the zone of abnormal perfusion, and development of collaterals or neovascularization as the case may be. In case the occlusion resolves with the formation of collaterals, by and large the neovascularization does not take place because the collaterals supply the blood to the affected areas, whereas in case the collaterals do not have sufficient time to develop, you get development of a neovascularization which can leak and lead to a vitreous hemorrhage. Macular thickening, cyst formation due to long-standing macular edema can occur in these stages, leading to an irreversible visual decrease. Clinical course of these particular occlusions is that most of them resolve without any sequelae and with the development of collaterals, whereas some of them lead to neovascular complications. Treatment, again in this case, as discussed previously for CRVO, is identification of the cause. Fundus fluorescein angiogram in case of an ischemic type of occlusion will show us a large amount of capillary non-perfusion areas in this sector, with significant macular edema and a decrease in visual acuity. The plan of therapy is according to the recommendations of the branch vein occlusion study, which give us the stage at which we initiate treatment for the macular edema with the use of laser, and this is a randomized control study which has been multicentric. Now, this is a clinical fundus photograph showing the fundus photos in the first few slides and an angiogram in the last few slides. In the first few slides on the left hand side, we can make out that there is an abnormal zone of arteriovenous crossing leading to a distal white fibrotic band. A few hemorrhages on the side indicate that this is a branch retinal venous occlusion in the resolving stage. The initial stage will give rise to more florid hemorrhages. If we follow the angiogram down with the cursor, we can find that all these areas are relatively more black as compared to the areas above. These areas above, they indicate a normal perfused retina, whereas these darkened areas indicate areas of capillary non-perfusion or CNP areas. If it is seen clearly, this is the edge of the perfused versus the non-perfused retina, and at that point we get the development of neovascular loops, which we find become hyperfluorescent as the angiography proceeds, and hence they leak. These new vessels are classical at the edge of the vascular with the avascular retina, and these are seen commonly in all occlusive pathologies of the retina, irrespective of the cause. Coming to central retinal arteriolar occlusion, this is the surrogate of a venous occlusion, but the etiology is completely different. The etiology in these cases more often is thromboembolic, vasculitic, vasospasms, and carotid dissection. It is very obvious that the blood supply of the central retinal arteriole comes from the heart, so any emboli arising from the entire circulation, from the chambers of the heart, from the carotids, may lodge into the retinal circulation, causing a central retinal arteriolar occlusion. So essentially it is very, very important to have a systemic screen of all these patients so that we do not miss the cause and keep on treating the effect. The common causes of retinal emboli are the cholesterol, the fibrinoplatelet, and the calcium, out of which the later two are notorious for causing a dangerous occlusion. The cholesterol emboli by and large are innocuous and they do not cause any significant occlusive episodes. The origin of the cholesterol emboli usually is in the carotids, whereas the other two are arising usually from the chambers of the heart and abnormal valves. The symptoms classically are like a curtain coming in front of the eye or sudden profound painless loss of vision. The signs, as we have discussed, any gross retinal pathology can give rise to a relative afferent pupillary defect. In case there is an associated occlusion of the cilioretinal vessel, and if it is present, we get a cilioretinal artery occlusion or infarct. Segmentation of blood flow is a very, very important sign. It's also called as cattle trucking. This is because of the sludging of the blood column and the slow flow, which can lead to this particular picture of columns of blood flow behind each other, which is commonly called as cattle trucking. Cherry red spot at the macula is also seen in the acute setting, which resolves as the central retinal artery occlusion resolves. In the later stages, we do get constriction of the arterioles due to lack of blood supply, which is followed by a pallor of the optic disc as a result of poor perfusion. It is very important to remember that this is one of the most common or rather most important ophthalmic emergencies with severe consequences to vision. The treatment, although it is emergency, it is reasonable to treat all central retinal arterial occlusions within the first 48 hours of presentation. Ocular massage, intravenous mannitol, intravenous acetazolamide, anterior chamber paracentesis, that is removing of some amount of aqueous from the anterior chamber by a small needle, are very important steps which try and dislodge the embolus into a more distal vessel, causing a resolution of the arterial occlusion. Pharmacotherapy with pentoxifylline, aspirin, hemorrheological agents to increase the perfusion can be used if not contraindicated. Even after doing all the above, usually the prognosis in such cases is poor. What we can do for such patients is identify the systemic cause and prevent this from happening in the other eye. Coming to another very important topic in terms of preservation of quality of life and the years of quality of life is retinopathy of prematurity. Retinopathy of prematurity was initially called retrolental fibroplasia because of the classical presentation during the years when the treatment was not so good. Low birth weight babies, besides the gestational age, are the primary predisposing factors for development of retinopathy of prematurity. In infants less than 900 grams and age of less than 25 weeks, the incidence is around 80 to 100%. So virtually almost every child of that low birth weight is going to develop retinopathy of prematurity. Incidence in India is 38 to 59% among all the low birth weight children. Contrary to the common belief, oxygen is not the cause of ROP. However, low oxygen and maintaining the saturation within 95 to 98% and slow waning from oxygen decrease the chance of development of a retinopathy of prematurity. Screening for retinopathy of prematurity is very, very important because early detection and treatment can preserve the vision of the newborn for life. Inappropriate screening procedures, late detections, and retinal detachment can lead to irreversible visual loss in these patients and a great loss to the quality of life. Retinopathy of prematurity is unlikely, even in severe forms, to develop before the 3rd week postnatally and usually within the 5th week, if at all. So it is very important for us to screen all the children within 3 to 5 weeks of birth. Examination of the retina with indirect ophthalmoscope and scleral indentation should be done at least within the first 30 days of birth. In case of early signs of retinopathy of prematurity, the patient can be kept under weekly surveillance, and if the retina is immature and the vessels are not up to the ora, then the patient is seen every 2 weeks till maturity, that is around 38 to 40 weeks of gestation. Essential to know that in the retinopathy of prematurity, we divide the retina into 3 zones at the time of examination. The examination is done with the help of an indirect ophthalmoscope using a 30 diopter or a 28 diopter condensing lens. The retina is examined from the center up till the periphery, where the nasal periphery is regarded as the limit of zone 2 and the temporal skirt is the limit of zone 3. The disc and the fovea are included in zone 1. The changes of retinopathy of prematurity are basically classified into various stages from stage 1 to stage 5. The stage 1 essentially is basically formation of a faint demarcation line. Stage 2 is formation of a ridge. And stage 3 is elevation of the ridge with truncation of blood vessels or a fibrovascular ridge. Stage 4 and stage 5 involve the formation of retinal detachment and the prognosis worsening from a sight-saving to a sight-threatening disease. In these cases, it is very important for us to know the location, the stage, and the extent in terms of clock hours. These three changes will help us in prognosticating or planning the therapy of such a case. Examination and classification of the disease, as we have already discussed, is depending on the location, as we have seen, extent of the disease in clock hours, and stages 1 to 5. There is something called as plus disease, which is very, very important for us to know. It consists of dilatation and tortuosity of the blood vessels at the posterior pole. This dilatation and tortuosity is basically a significant indicator of ischemic pathology and ischemia. This form of disease, if in addition to any of the staging or the grading of the disease, needs urgent intervention. Important definitions that we need to know in cases of retinopathy of prematurity is rush disease, which is zone 1 ROP, confined to the central zone, because maximum part of the retina will be immature, so it is very aggressive disease, and along with dilatation and tortuosity of the vessels of the posterior pole is called as rush disease. This rush disease is relentless and fulminant and needs urgent and vigorous treatment in terms of panretinal photocoagulation. Pre-threshold retinopathy of prematurity is basically a zone 1 or a zone 2 disease with the required clock hours as mentioned on the slide. Threshold ROP is that stage of retinopathy of prematurity which needs treatment, and this basically has a significance of 5 to 8 clock hours of contiguous or intermittent retina. If these amount of clock hours are involved, urgent therapy is indicated to prevent blinding complications of the disease. The treatment for threshold ROP should be initiated within 72 hours of detection. Modalities of treatment of retinopathy of prematurity, as we have discussed as a common denominator for all vascular lesions, consist of laser, intravitreal injection of anti-VEGF drugs, cryotherapy and surgery. Cryotherapy has a role treatment of retinopathy of prematurity specifically because in these eyes periphery may not be easily seen in some cases, like for example in later stages where the media may be slightly hazy or presence of tunica vasculosa lentis, which does not allow the visualization of the peripheral retina. The laser is a predominant form of treatment. Most of the patients respond very well to a well done laser, and all the changes regress with normal development of the retina subsequently. The scarred retina in the periphery remains as a scar. Sometimes it can lead to traction on the macula, and hence the patient should be always observed every 3 to 4 monthly for the first year to see for changes, including the retinal changes and the refractive errors. Surgery is only reserved for stage 4 and stage 5 of the disease, where there is a retinal detachment, and visual rehabilitation is extremely important for these cases who have undergone surgical treatment because normal outcomes are very, very rare in such cases. Coming to a very, very important topic in terms of the multiple choice question and somewhat less relevant clinically is a cherry red spot at the macula. It is very, very important for us to understand, to easily remember, for the amount of importance it is given in examinations is quite significant. For that, we have to understand the clinical anatomy. The parafovea has the thickest layer of the ganglion cells, and the foveola is the thinnest part of the retina. Hence, relatively, the foveola appears red as compared to the surrounding because of the thinness and the choroidal see-through. The spot, hence, can be produced either by contrast, as in the surrounding retina being more whiter than the foveola, or by color, the foveola getting more red hue as compared to the surrounding. Discussing the first part, by contrast, the foveola can appear red as cherry red spot in case of central retinal arterial occlusions. This causes the edema and thickening of the ganglion cell layer, which appears white, and hence the red stands out in contrast. Deposition of lipids in the ganglion cell layer in metabolic diseases, which we will discuss. Edema of the retina as in trauma involving the fovea, which we commonly call as Berlin's edema, which causes a transient axonal stasis and edema, leading to a white patchy area around the fovea and the highlighting of the macular cherry red spot. Storage diseases involving the ganglion cell layer, they are sphingomyelin and cholesterol depositions like in Niemann-Pick's disease, Tay-Sachs variant of gangliosidosis, Sandoff's variant of Tay-Sachs, and generalized gangliosidosis. So all in all, basically a storage disease of the sheaths of the ganglion cells, because of which the white deposition causes a sharp contrast and appearance of the fovea as a red spot. As far as the color changes are concerned, in terms of color of the foveola gets a more red hue with the surrounding as compared to normal in cases of macular hole and in cases of a macular hemorrhage. In these cases, because of the increase in the contrast as a result of a hemorrhagic spot, and the surrounding retina being normal, the macula appears as red. So in short, in this particular module, try to see a common pathway for vascular lesions to simplify their understanding, simplify the method of treatment, and to form a common pathway which makes the process very less complicated.